Excellent. Well, welcome everybody on this lovely Friday morning. Thank you for joining us for the second webinar in our webinar series on equity, diversity, and inclusion in patient-oriented research. Today, our session is looking at impact for all, equity, diversity, and inclusion, and knowledge translation in patient-oriented research. First off, I'd like to start by saying that we wish to, pardon me, take this opportunity to acknowledge that the University of Alberta and the University of Calgary are located on the territories of the people of Treaty 6 and Treaty 7, and we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Nations peoples of Canada, whose presence continues to enrich our vibrant community. As we start off this session, I'd like to mention that we will be recording the presentation portion of this workshop. However, the discussion portion at the end will not be recorded. Throughout the session, we will have one of our staff members doing some live tweeting. So if you do not wish to appear in the images, please ensure that your video camera remains off. And a few words of housekeeping. Please do keep your webcam and mics muted during the presentations. And if you do have questions, please use the chat box throughout the presentation. During the question and answer phases, please use the raise hand tool and you will be asked to unmute your mic and you'll be able to ask your questions. So we do strive to encourage a safe space for dialogue where you're able to express honest opinions, thoughts, and attitudes without fear. And to help foster that, we have a set of rules of engagement for the discussion, and I'll just go through these. So we assume a positive intent. We're all doing our best to the best of our abilities with the knowledge that we have. We recognize and value the experiences, abilities, and knowledge each person bring to the discussion. We practice active listening throughout the session, listen to understand, not to respond, and ask clarifying questions, avoid interrupting, pause and think through your comments before you make them, challenge ideas and not people, and never demean nor embarrass a person, and be open to being challenged or confronted on your ideas or prejudices. We do have a pre and post survey that we'll ask you to fill out before the webinar, well, at this time, and then again after the webinar. And the purpose is simply to find out what impact the webinar has had on your learning and understanding regarding EDI and patient-oriented research. And Amanda, if I could just get you to put the survey link into the chat, that would be great. And please fill the survey out if you have a chance as we're moving along here. I should have started the session actually by introducing myself. I'm Kelly Buckrice, and I am the Associate Director for the Alberta Spore Support Unit Capacity Development Platform. And I work with our lead, Dr. Sophia Ahmed, who is with the Libin Cardiovascular Institute at the University of Calgary, Amanda Wagner, and Diane Christensen, who have pulled this session together. Amanda is our wonderful program coordinator with the capacity development team, and Diane is an integral member of our team as our project assistant. Our speakers today, I'm pleased to introduce Dr. Jia Hu, who is the Medical Officer of Health for the Calgary Zone and has been involved in leading the 19 to 0 project relating to COVID-19 vaccination uptake. And along with his colleague, Dr. Cora Constantinescu, who is a Pediatric Infectious Disease Clinical Assistant Professor at the UOC, also involved with the 19 to 0 project. Dr. Shannon Scott, who's a professor in the Faculty of Nursing at the U of A and is the principal investigator of the ECHO Research Group at the University of Alberta, alongside her colleague, Dr. Sarah Elliott, who is the Assistant Director of the Alberta Research Centre for Health Evidence and Program Manager of Cochrane Child Health at the University of Alberta. Dr. Lisa Hartling, who directs the Alberta Research Centre for Health Evidence in the Department of Pediatrics at the University of Alberta, and Julie Liang, who is a member of the Pediatric Parents Advisory Group, which we call the Ppag. And I'd like to also welcome our speaker, Catherine Turner, who is with the CAMSOLVE CKD network as the Indigenous Liaison Manager, and her colleague, Simone Du, who is the Special Projects Coordinator with the CAMSOLVE CKD network. All right, so the overall objectives of this session are to describe different types and measures of research impact that's afforded by inclusive patient-oriented research. POR is the abbreviation of patient-oriented research. To explain how strategies to ensure EDI in patient-oriented research align with the integrated knowledge translation model, and to describe how inclusive research teams influence research output and knowledge translation processes to enhance health equity and outcomes. So we'll have a series of presenters in groups. So we will have a number of presentation topics with the groups of presenters presenting. We'll start first with Dr. Hu and Dr. Constantinescu presenting on understanding and addressing vaccine hesitancy, and also discussing BIPOC considerations in encouraging vaccine uptake. Dr. Scott and Dr. Elliott will speak about developing knowledge translation tools for diverse audiences. And following that, we'll have Dr. Hartling and Dr. Liang speak about working with a patient or parent advisory group, reflections from a researcher and parent member of that group. And we'll round out the conversation at the end with our last presenter group, who will present on two-eyed seeing approach to integrated knowledge translation in Indigenous community research. And after that, we'll have some time for final questions and a wrap up and some key takeaways. So I think those are all my slides. I will stop sharing my screen and I will ask Dr. Hu and Dr. Constantinescu to share their screen. And in the meantime, I will say a few more words about our friend. Dr. Hu is the primary care vaccine rollout lead at the Alberta Medical Association, a clinical assistant professor at the University of Calgary, the chair and co-founder of the 19 to 0 initiative, and also a family physician. And he also works at the East Calgary Health Centre, which is an inner city family medicine practice serving marginalized populations. And Dr. Constantinescu is a pediatric infectious disease specialist with the Vaccine Hesitancy Clinic at Alberta Children's Hospital in Calgary, whose work at the Vaccine Hesitancy Clinic at the hospital informs her contributions to the 19 to 0 efforts. So I'll invite you, if you have slides, to share your screen and begin your presentation, and welcome.
Hey, thanks. We were going to have slides, but then of course, since I'm over, because she's like a more responsible human being than I am, basically on every level. I think if I were to just, Secor is like Canada's leading vaccine hesitancy practitioner, one of those people. And I probably do more like public healthy type stuff. And my understanding is we're talking about drivers of vaccine hesitancy, and you wanted a bit of a focus on BIPOC populations specifically. Cool. All right. Well, I reduced your slide quite a lot, but I'll start with this slide actually. So, hello, thanks for having us. This is a map of Alberta's vaccine uptake by like LGA, large geographic area. Pretty hard to see Edmonton and Calgary, but you know, in the big cities right now, in Alberta and also everywhere else across the country, vaccine uptake is quite high actually. And I would say it's also quite high for what I call urban vulnerable populations. So, you know, a lot of the BIPOC people, a lot of sort of, you know, racialized newcomers. And maybe it wasn't that high, or we didn't think it'd be that high 8 months ago. But I think that if one actually looks at the map, where you see lower uptake basically is everywhere outside of the big cities. Rural Alberta, I mean, the sort of little Bow Valley area, this little part by the mountains is decent. But, any low uptake areas tend to almost entirely be in rural places. And as I can sort of explain some reasons for that in a second, but if we think about sort of what are the drivers of vaccine hesitancy in any population, actually, the sort of WHO has this framework, the 3Cs framework, confidence, complacency, and convenience. And we'll sort of dive into those for a little bit, but there's some, additional things like keeping with the C theme calculation, because people, these are sort of risk benefit discussions and collective responsibility, but I'm going to sort of hone in on these three actually. Right. And so I think it's actually a really, really good way of thinking about vaccine hesitancy in the sense, maybe I won't call it vaccine. I'll call it, this is a really good way of thinking about whether or not people get vaccine or not. And I think that these three factors tend to in different proportions lead to people getting more vaccine and less vaccine, or populations getting more vaccine or less vaccine. And we'll just go through them right now, actually. I'll start with complacency, the middle one. It's kind of the easiest, actually, in some ways to understand. But, the extent to which people get any vaccine or pursue any sort of health behavior is sort of linked to how worried they are about, what happens if you get COVID, or if you don't do X, Y, Z, right? And so I think that Canada actually has one of the world's highest vaccine uptake rates, leading maybe first, second compared to the UK, tied with the UK. I mean, there's countries like the UAE, Qatar that have higher vaccine uptake. But, we're doing super darn well, actually, far better than I would have anticipated. Maybe Corin, I would have anticipated a year ago, the global leaders. But the places with much low, so if you look at other places, let's say in Asia, Hong Kong, China, Australia, Japan, places that have had very little COVID because their governments generally have managed COVID a bit better, you see much lower vaccine uptake. And sort of this bucket, sort of, if you don't think COVID's a big problem, and this is not the same as thinking COVID isn't real, very few people don't think COVID is real, but it doesn't affect you very much, doesn't affect your loved ones very much. It's not, you're less motivated to sort of get the vaccine. And, if I sort of put a BIPOC lens on that, I would say that a positive driver for vaccine uptake in that population has been the fact that, they have been generally hit pretty hard by COVID in the first wave, like Cargill, pretty bad. But, in general, just across the country, we've seen, a significantly higher proportion of disease, hospitalization, death, et cetera, in that group. Going back to the little map of Alberta, part of the reason why I think rural Alberta and rural period does not want vaccine as much as Edmonton or Calgary is because while there have been some large outbreaks up in Fort Mac, in the Bow Valley, by, if you're in a very rural place, you see less COVID, you've had less COVID, around you. And that really, really is sort of a huge driver. I think that, so this is going to be more of a problem moving forward into the summer, and especially I think if we want to sort of start immunizing kids, under 12, and vaccines get approved for them, because the urgency to get a vaccine if there's 2,000 cases a day and ICUs overflowing is much higher than if there's 80 cases a day and the hospitals are coming along just fine. Now we'll go to confidence, which is sort of like what generally interpret as hesitancy, but there's a lot of it's just like, how much do you trust the vaccine? Are you concerned about its safety? And one of the big sort of some underlying drivers of this sort of if you survey people is do you trust government? Do you trust public health? Do you trust Health Canada? Do you trust pharma companies? And this is where actually I would say that both sort of vulnerable populations and some of the rural populations actually have, lower trust in all those things, right? So if you're sort of in this, for example, do a lot of work in, let's say, the GTA as well, right? And so, the populations that have traditionally been hurt by government, so, Indigenous populations, Black Canadians, again, go back to, people who worked at big meat plants that got massive outbreaks, they probably trust government less because, they sort of a good reason to trust government less, perhaps. And I think that on the other side of the equation, when you look at sort of like rural Alberta, you have people who tend to be, more conservative on the political spectrum. You don't necessarily like big government. Certainly don't like Trudeau very much on average. And that also leads to people not wanting to get the vaccine. This is sort of very, very apparent in the United States right now. If you look at sort of what's happening there, you have these blue states, democratic states, with very high vaccine uptake, comparable to Canada. And then you have these red states, Republican states, like in the South, where some states have a first dose uptake of 30-40% only. And, there's huge amounts of mistrust in government. And this is sort of that trust in institutions actually is this huge actually drive for how much people really want vaccine or not. And this is, anyway, so that's sort of the confidence piece there. And then the last thing is like convenience, which I just put a little access beside it. Convenience maybe sounds, but it's really just like how easy is it for somebody to get the vaccine, right? And there's a few ways you can have less access. One way of having less access is just not, having vaccine, let's say within like a 50-kilometer radius of you or something like that, right? The other way you might not have access is if, even if, all else being equal, even if you're sort of a rich person and then you like a poorer person and, like the pharmacy or whatever is the same distance, if you don't have sort of access to transportation, access to sort of sick leave, access to leave for vaccine side effects, the ability to go see your doctor, to like ask questions, you don't have time off, like that also takes away sort of access. And, I think that right now in the cities, we certainly have pretty darn good access in the traditional sense of the word. I think that, earlier on in the pandemic, and it depends where you're looking at, where vaccine was sort of primarily given more at some of these large public health centers. Pharmacies didn't have that much vaccine. It was more of a problem in cities. If I go rural, like you really do have less access, right? Like having, like saying you have a pharmacy within 10 kilometers where you live, like that sounds easy for somebody who really wants to get the vaccine. But it's, less accessible if you're not sort of desperate to get it. There is this sort of thought experiment that I play out in my head where, if you literally had a vaccine clinic in every street block, so like 1 million access points, then probably more people get the vaccine. And, I think this type of access piece does, again, tend to disproportionately affect people who, come from lower SES and the BIPOC populations as well. And so I think those are sort of some of the main, well, these are, I think, the three main drivers of hesitancy. And if you think about like how much a particular population has confidence or lack thereof, complacency or lack thereof, like an access and lack thereof, you can sort of begin to understand why some groups get the vaccine more and some groups get the vaccine less. And I think understanding these drivers also allows you to begin to do something about it, right? And so, I think we'll start from the confidence piece, and I'll just say, a huge amount of work, I think, has been done in a good way to build trust amongst vulnerable equity-seeking populations, because we sort of recognized maybe like a year ago that this might be a problem. And, there's tons of organizations that, have served these, well, I shouldn't say tons, but there are organizations that do serve these populations. And, like we've had less pop-ups, for example, in Alberta, but, they've done a lot of, I'll talk about pops and the access fees, but you have groups who've just built trust in communities. And generally the way you build trust in communities, I think you tend to want to, if you're a researcher, like a public health person, somebody like me at Cora, like you generally want to work with groups that already work with the community. So in Calgary, we have some really good newcomer serving organizations like CCIS and Center for Newcomers. The other thing you do that I think is quite critically important is you don't necessarily just start by talking about vaccine. So early in the initial rollout of the vaccine, I think a number of sort of, vulnerable groups are like, why are you just telling us to get vaccinated? Like, is that like, because like you don't want pandemic to affect you? And so I think that a lot of work is actually done supporting people's actual, like whatever needs they actually felt existed. And so, a lot of that was around finding people who had to, quarantine or isolate, income support or food support and some of those things, and like really meeting communities where they are. Like it's not like rocket science in a way. Like, it just like help people what they want help with. And, but that does take quite a lot of work. And I keep on talking about the rural stuff because it's clearly on my mind these days, because I feel like that's the only place you have like really low uptake, but to do that, let's say in a rural area, you have to find those trusted organizations, and I think, like religious groups, I don't know, 4-H clubs, like farming type, like agriculture type companies. Well, sometimes they trust, some there's not, but that trust needs to be built and it needs a bit of time to be built. And so that's that. On the sort of complacency side, again, I think that there is no substitute for having your ICUs overflow to create a sense of urgency in the population, but that's not probably the best way to create that sense of urgency. And I think that, we have tried to, message about things like, we talk about like if you're younger, the long hauler can affect you. I think, for, certain like demographics, talking about how, like nobody wants to go through a lockdown again, but again, just like emphasizing whatever people might be concerned about, and just the severity of COVID, no matter who you are. But, we are going to lose the sort of tailwind of, COVID disaster, and that, like, it's suboptimal. And then on the access piece, I think that this is probably, again, where with a lot of the sort of, vulnerable sort of equity seeking groups, you have had, depending on the province you're in, quite a lot of work done actually standing up like clinics in communities, like where some of these, where, people, racialized newcomers live, staffed by people from the community. That's been quite effective, I think, actually, versus having them go to a big, public health clinic in downtown Toronto. And so I think that, right now, like we're doing pretty good. I think among sort of like BIPOC populations is really good. Recently, there was a big slew of like grants that came in, and, chatting with all the agencies that work with these populations, we're like, we don't really know who to go after anymore in a good way. But I think that's sort of like the general way to sort of think about the issue. Cora, did you want to add anything?
I think, especially when we're talking about specialized populations, it alludes to what you said before, Jean, and that's that the messenger is so much more important than the message. And in healthcare, we're very well attuned to how to build message, but when it comes to vaccine hesitancy, what's been shown time and time again is that the messenger is really important. So again, this idea that we have to tailor the message to whatever the underlying problems are, whether they're within confidence, complacency, or accessibility. But at the same time, we have to find those vaccine champions on the ground within those groups that group identifies with and has common ground with. Otherwise, the message just does not have the same resonance, because trust and social influence come up over and over again as the main drivers when you talk about confidence for all groups. So this is what's been kind of the same across. It just takes obviously it has a different approach based on whether you're looking at, rural population, or you're going to target the 20 to 40-year-olds, or you're going to target a specific BIPOC group. But really, the principles of trust and social influence are the same. And again, it just goes to show that those vaccine champions, those people on the ground from those particular groups, are key to passing a tailored message on. That's all, I think. Otherwise, Jai has done a fantastic job of outlining the main principles of vaccine hesitance around COVID.
Cool, thank you. And Cora, there's some other stuff around like how to have like one-on-one conversations that I included, but I'm not sure that's like the focus of what people want to hear about. I think we could take some questions, or we could give some examples actually of how like this has worked well. I don't know, Kelly, what do you think? You're nodding. I don't know.
Yeah, we do have a question, and then maybe it would be very helpful to see, to hear some examples. And just from my own point of view, I'm familiar with some of the efforts of BIPOC doctors in the United States to encourage vaccine uptake, as Cora was talking about social influence. The vaccine selfies on Twitter have been very influential. But I'll go to the first question in the chat. Diane has asked, what about those who are concerned about the side effects perceived as dangerous of vaccines? What do you suggest we say to them? And maybe could this be something added to the confidence list?
Yeah, so this is a great question, because if you look at safety, so if you look at confidence, the top thing that comes up is trust. And then if you then try to break trust down, a lot of it has to do with side effects. So that's really key. And we've actually asked these particular questions in our research and our surveys and so on about how to address side effects, because again, you don't want to scare people and put them off with the idea of side effects, but at the same time, you also don't want to sound like you're dismissive. So I say, whenever you approach anybody with a vaccine conversation, you have to make sure you have some common ground with them. So it goes back to this idea that messenger is important. So no matter what you're going to talk about, don't hone in on the side effect. First, build some common ground, and then show true curiosity in terms of where they're at. So what are those real side effects that they're actually worried about, as opposed to speaking about maybe the one or two side effects you know of? So again, you try to get to them. And then when we ask this question to people, here are a few principles about side effect conversations that seem to hold. So one is, vaccine hesitant people get turned off if you throw platitudes at them. So if you say, oh, vaccines are safe and effective, just take them, that actually doesn't do anything. Those only for the people who are already confident does that help, because it's a validation. It doesn't actually change the mind of any vaccine hesitant person. So what they have said to us from the qualitative research we've done is that they want to hear the actual side effect addressed head on. So again, you're going to build that common ground. You're going to show curiosity and say, tell me more about what truly worries you about it. And then if they say things like, well, I'm worried about measles and autism, then you say, oh, okay, that's fair enough, but that doesn't apply to this vaccine. Let's go back to your concern. So you always try to bring them back to that particular concern. And they say, well, I'm worried about myocarditis in my child and COVID-19 vaccine. Then you have to address that particular concern, and you tell them what you know about it, as opposed to saying, oh, well, it's really rare. Don't worry, it'll all be good. Get the vaccine. That actually doesn't resonate. So you have to meet to address it head on. But again, that specific concern that they have versus some other concern that you may know about more that you're tempted to talk about. So you keep it very personalized, keep it exactly to what their issue is.
Excellent. Thanks very much, Cora, for that response. So Laura has a question. Her question was, have you had opportunities to partner with organizations to get the appropriate messages out? And this question might actually lead nicely into one or two examples.
Yeah, I mean, I think that one of the things we really try to do is support as many organizations that have questions as possible to get those. I mean, we work with like school boards and NGOs and municipal governments and all sorts of healthcare worker groups. And every single, I think we work with every single type of organization in this province and other provinces as well, right? And so, I mean, what's a good example? So like, let's say with, getting the meat plants in Alberta immunized, right? There's sort of like a constellation of sort of newcomer serving organizations that we've been working with for quite a long time. But when it came time for vaccine type stuff, we worked with them, did town halls, did translations. Also worked with, like, when I think about the ecosystem, it'd be these groups that, serve, like resettlement agencies they trust, work a lot with the unions, and we also work with the employers, right? Because you sort of like, there's no, you also look for what I call like a confluence of interests, and like, Cargill may not be the best employer, but they certainly wanted their employees vaccinated for various reasons. But I think that, like, if you're going to really work, I think, with like a vulnerable, specialized population, like sharing a bunch of frigging like talking points ain't going to do much, right? Like, as in, like, how do you actually build? And this is the problem, right? People ask about evidence, right? Like, you might do an evidence. Like, if you define evidence as something that's peer reviewed, then I'll say that, like, most research done on this during COVID is pretty useless because your cycle of peer review is so long that it doesn't really help, right? Like, and there's like the data you need to like get shit done, and like the stuff you like, turn into a publication that may be translatable, but like there's like less, what's the word? There's less external validity apart from the approach, which is to like make friends with people, and you make friends with people by like helping people out. And so, yeah, messaging. But I think the time when, like some of the things we did probably that built trust was in the first wave, like at that big meat plant outbreak, was finding $100,000 of food for families because that was their primary need, right? And, stuff like that. And like just messaging in general is very useful. But if you're talking about a very specific population where they may have mistrust, like, I'm like, I don't know how much it's going to do. So, yeah. Sorry.
Cora, was there anything you wanted to add to that?
Well, I was thinking maybe I can give you an example. So, we, Ja has in 1920 has done a lot of work on partnering with multiple groups actually for the last, I don't know, I've lost track, a year, I think. But I'll give you an example of where the messaging has to be a bit different. So when you look at more of the rural groups, if you have to, it's a lot of it is about personal protection. So when you ask them what makes the intent change, is about the idea that I am personally not protected if I don't get the vaccine. So speaking about community, speaking about collective responsibility doesn't resonate with those groups, because at the end of the day, they make the decision based on personal protection, which is very interesting. However, when you look at some Indigenous communities, the approach there is about collective responsibility, about saving elders, about saving culture. So when you actually message certain communities, like some of these Indigenous communities, it's not about the personal protection. That doesn't resonate, and you do have to put it within the context of collective responsibility. So that again shows it's not one size fits all. You really have to understand where are people at, and you have to meet them where they're at. And it's hard because often we want to meet people where we want them to be at, not where they're at. But again, it just goes back to about the same principles. You have to find out the reasons, and then the message has to be tailored to that. So that's probably one of the examples on, some of the campaigns that have been put out there, and how they had to be tailored.
And this is a good point. And so you're right. So like one thing we always do is, like Cora's right, different populations just want different messages, their population levels. So you get that, like you survey, you ask, do focus groups, and then you develop messaging and you basically test it. That's like what marketing companies do. But again, I'll say, like, the reason why, like right now, like vaccine uptake is quite high on reserve, like in Calgary zone, is because there's been like a hell of a lot of work done, right, to build that trusted partners to build that, right? And I think that the main advantage of, like, so we do a lot of like mass marketing campaigns, right? And so that's like a really good way of reaching like 4 million people, like with a very light touch approach. But I think that type of thing, like, I would trade that, and that is quite critical because, like, you want to reach a lot of people once sometimes. But at the point of like community, like this trust community building piece, right? Like I think the effects of working with, let's say, like really strong, like Indigenous partners when you'll do on-reserve vaccinations, that or working really closely with newcomer serving agencies, like far outweighs like sort of like macro messaging. Like, however, macro messaging is more targeted, like the general population with some segments. So, but yes, good point. Thank you for raising that, Cora. it's very good. Yeah.
Excellent. Thank you very much. And I think that's an excellent segue into our next presentation. So I will call on Dr. Scott and Dr. Elliott to queue up your slides. And in the meantime, I will say a few more words about both of you. Dr. Scott and Dr. Elliott will be presenting on developing KT tools for diverse audiences. Dr. Scott is a pediatric nurse and professor affiliated with the Stollery Children's Hospital Foundation Distinguished. She is a Stollery Children's Hospital Foundation Distinguished Researcher and a Canada Research Chair in Knowledge Translation in Child Health at the University of Alberta, and is the principal investigator of ECHO Research Group, an internationally recognized program of nursing research focused on child health and knowledge translation. And she's also a founding co-director of the Translating Emergency Knowledge for Kids group, which is a nationally funded initiative looking at ensuring every child receives the highest standard of emergency health care. Dr. Elliott is the assistant director of the ARCH organization at the University of Alberta and is also program manager of Cochrane Health Program. The Cochrane Child Health Program. Sarah works very closely with Dr. Lisa Hartling and Dr. Shannon Scott to support their collaborative research program. And the focus of the ARCH ECHO program is to improve health outcomes of children through the application of the best available scientific evidence by creating fit-for-purpose knowledge translation tools. So welcome both of you, and I'll turn the mic over to you. Thanks very much.
Great, thank you very much, Kelly. Sarah and I are really happy to be here to share our experiences of developing knowledge translation tools for diverse audiences. I just wanted to share with the audience this presentation and the next one by Dr. Lisa Hartling and Julie Ling are related. They're coming from our same shared research program. So just to provide that context. We wanted to disclose that we have no conflicts of interest to declare, and we wanted to acknowledge the generous support of our funders in the research that we are going to share. So in terms of our presentation objectives, the first one is to learn about how we work with parents to co-develop knowledge translation tools for common childhood health conditions. We're going to share our innovative co-development model that integrates the best available synthesized research merged with parents' experience in order to create innovative knowledge tools. And we will also share our experiences and the challenges in creating these products for diverse audiences. In terms of the goals of our research, we have four main goals. The first is to engage parents in decision-making about the use of health services and treatments, to involve parents and families in the development and evaluation of effective knowledge translation tools. And the purpose behind the innovative products we develop is to increase parents' knowledge about common childhood illnesses, as well as to increase their confidence in managing them. I wanted to also acknowledge that a very important vehicle that's helped us to be able to involve more diverse audiences in the development as well in the dissemination of our work has been a national organization that Dr. Lisa Hartling and myself helped to co-develop with Dr. Terry Clausen, Dr. David Johnson, and Mona Jabor, translating emergency knowledge for kids. And this organization was developed because 85% of Canadian children who need emergency care are treated in a general emergency department that's not part of a children's hospital. And that piece is really important to keep in mind. We're really trying to ensure that the best available research evidence is available to all Canadians, irrespective of where they live. And we're going to share our development model with you in more detail. But one of the first steps that we did in the development of TREC that has also informed the development of our research program was a national needs assessment of general emergency departments in Canada. We went out and asked healthcare providers providing care to children, their information needs regarding taking care of acutely ill children, as well as parents and families who brought their children to a general ED for care, to really involve them in determining the priorities and areas for us to focus on. We have subsequently updated this work through some priority setting exercises. So when we talk about our innovative knowledge translation tools, we wanted to share with you sort of what they looked like. So as we go through our presentation, you can get a sense of what we're talking about. So back in 2004 and 2005, we started to develop storybooks. Here on the left side of the screen, they were in hard copy, and they provided the best available research evidence, but embedded in a story. And we involved parents in the development and evaluation of these tools. As our research program evolved and developed, we were actively working with parents and trying to understand their information needs and how they wanted to receive this information. And so we started to develop whiteboard animation videos, interactive infographics, ebooks, and audio ebooks. So you can see on the right, there's some screenshots just to give you an image of how the tools look. Our tools are all freely available on TREC with 2ks.ca. In terms of our development model, if we envision this like a clock, if we start off at 12 o'clock, you can see how the new topics for our tools are identified through various stakeholder groups and priority setting activities. So the national needs assessment that I mentioned. We start with parent engagement, and we do qualitative interviews to gather parents' experiences and identify information needs and preferences for knowledge exchange. So through a needs assessment, for instance, if we've identified that parents would like information about children's croup, for instance, we would then design a qualitative study and be purposefully sampling diversity of families with a child with croup. So that's the first stage. At the same stage, we are undertaking and learning from previous research, doing systematic reviews and knowledge synthesis of diagnostic and therapeutic management, as well as the existing literature looking at parents' experiences and information needs. And we combine the results of the qualitative study with the knowledge synthesis to start developing prototypes of our knowledge translation tools. And we've shared some examples of how they look. Then we start doing an initial evaluation of the tools. We get feedback from our clinicians through TREC, as well as through Pediatric Emergency Research Canada. And we also show prototypes to our parent advisory group. You see in the center of our model, our parent advisory group is at the center, and that is to demonstrate and show how critically important our parent advisory group is at all stages of this process. Based upon the evaluations and the feedback we receive, our prototypes undergo refinement. And this is an iterative cycle. In some cases, we have to go back more than once to get additional feedback after refinement. And then we do usability evaluation of our tools in a diversity of settings across the country. We typically want to be doing usability evaluation in rural, remote, and urban settings. Typically, we go to emergency department waiting rooms because that's where our population of interest is. It's parents waiting for care with an acutely ill child. And we ask them to view our tools and answer 9 questions about them. When usability is complete, then we do purposeful dissemination through various means such as stakeholder websites, social media, and health system channels. So just some further images of our tools, screenshots of some of our whiteboard videos, just to give you a sense of the look and the feel. Our infographics, in some cases, they allow parents to be able to customize the information they receive, either based upon the age of the child that they have or the severity of symptoms. We've also responded to information needs in response to the pandemic. And this just gives you a sense of where we've done our usability testing. So from coast to coast in Canada, and we also do usability testing in the north. So we're really trying to get diversity of perspectives in testing our tools. This just gives you some insight very quickly into our results from the usability testing on a 5-point scale, looking at usefulness, simplicity to use, and length. I also want to say, in terms of our tools, they are all viewable on smartphones. So we've taken the time to ensure that the whiteboard animation videos, ebooks, and interactive infographics are viewable on smartphones, but they are all also available and viewable on the web. This just gives you a sense of the topics that of tools we have developed over time. And in terms of diversity across our evolving suite of KT tools for parents, we document elements of diversity to ensure representation of the Canadian population. So we are trying to reflect diversity in terms of family diversity, gender, culture diversity, ability, age, education, and socioeconomic diversity in the presentation of the information. In terms of the impact and reach of our work, our videos are available through HUTV and Alberta Health Services, so playing in emergency department waiting rooms throughout the province, as well as on TVs in hospitals. And so through that venue, we do have significant exposure every month. They are also, over 34,000 views of the tools on YouTube, and many page views from all over the world in terms of our tools. We're actively working with Alberta Health Services to get our parent tools integrated on the electronic medical record, so trying to get them embedded in Connect Care. And as I've mentioned, they are being viewed across Alberta Health Services as well. I'm going to turn it over to Sarah now, who will talk about the cultural adaptation of our work.
And can everybody see my screen? Yeah, perfect. Okay. Multiple screens, you never know what's going on where. So I'm going to talk a little bit now about, as Shannon said, how the tools have evolved over time to be more inclusive and representative of our diverse parent needs. And I'll specifically speak to a few cultural adaptation projects that we've carried out over the last couple of years, as well as some challenges and highlights of working in this space. So I think we can all recognise that Alberta is a very diverse and multicultural province, and it's home to a number of different cultural communities in both urban and rural settings. And these communities may have very different communication styles and ways in which they interact with the healthcare system. And additionally, cultural practices and socioeconomic factors could impact how they access and view healthcare resources, as well as their preferences for receiving information. So through working in this space, as Shannon just pointed out, for a number of years, and through conversations with the Pediatric Parent Advisory Group, which is at the core of that ArchEcho model, and through conversations with our community stakeholders, we started asking ourselves, how can we create or adapt our current knowledge translation tools to meet the needs of our diverse audience?
We're only on your title slide there. I don't know if you...
Oh, no. Okay.
Sorry about that.
Yeah.
Sorry to interrupt.
No, that's fine. That's why. Let me share. Has that changed the screen?
Yeah, much better. Looks great.
Does that change the screen?
Yes, looks good.
Okay. So to help guide us with this, we performed some pilot testing within a few local communities here in Edmonton. Firstly, we decided to translate and test a tool in French, as this is not only an official language of Canada, but there's also a large Francophone community in Edmonton that we could tap into for user testing. And then, according to one of the most recent census results, Tagalog was found to be the second most common language spoken within the home in Alberta. So we did some work with the Filipino community. And then acknowledging that in Alberta, there are 45 First Nations in 3 treaty areas, representing traditionally underserved communities. We wanted to understand if these tools were useful and something Indigenous healthcare providers would use. And we also had contacts at the Stollery Children's Hospital Children's Indigenous Health Program who were interested in working with us on this study and really helped guide that one. And then we're also aware that there are other groups in Edmonton or Alberta, such as refugee or newcomer groups that might have very different needs and preferences for information sharing. And it could look very different to some of the more assimilated communities, such as the Filipino community. And last year, we were lucky enough to work with a summer student who's part of the Somali community, and they really helped broker relationships with those community members and set that project forward. So the approach we took for these projects was slightly different, as we were asking community members slightly different questions for different audiences. For the French community, we recruited and interviewed parents, and we used the Create whiteboard animation video, and that was translated into French, and no character or stylistic changes were made for that one. And it might seem like a simple process, but I just wanted to point out that these are some of the key steps that were taken. So there's a lot of back and forth with the production company to get this script translated to French, provide narrators, the digital images, as well as the text. And throughout the whole process, stakeholders were engaged and involved. And one of our key questions for this was, what was the appropriateness of the linguistic adaptation? For the Filipino community, again, we recruited and interviewed parents. We used the group video again, and this was translated into Tagalog, but we also made some character and stylistic changes to the tool. And again, just wanted to show the step-by-step process. It wasn't just a quick translate it, redo the script. A lot of effort, time and resources were involved in actually creating a tool that was specifically set out to reach the Filipino community. And for this one, we're wanting to know what was the how appropriate was the linguistic and cultural changes that were made. For Indigenous healthcare providers, we actually showed 2 different videos that were quite different in their style and format. And for the Somali group, we talked to healthcare providers and knowledge brokers. And for this, we showed them 4 different topic tools. So we showed 2 videos, so what to expect the emergency department, the Croup whiteboard animation video, so there was some consistency across the studies, the bronchiolitis ebook, and the fever interactive infographic. So it was a much simpler process in that everything was done in English. The tools weren't adapted from the outset, because we really wanted to know what was the usability of these tools in their current form for these communities, and what were some cultural considerations we would need to consider when presenting health information to these communities. So in general, it was really great to see that parents, healthcare providers, and knowledge brokers thought the tools were really helpful, had good visuals, and were considered user-friendly, and that also being in the English language was fine. And it was really great to see that the communities were really happy to be involved and they wanted more health resources like these. Looking across the range of communities, so there was 4 major themes that we think captured the feedback from these different groups, and they related to language, format preferences, representation, and accessibility. And like I said, while it was thought respectful and helpful to have it in the different languages, English was just fine. It was noted, though, that the Somali community preferred oral communication, so verbal instructional tools, not so much written text or written animation. Interestingly, the video was the most preferred format across the groups, but it was noted by the Indigenous healthcare providers that written pamphlets might be useful. And for the Somali community, group learning sessions were often the most successful in conveying information. So perhaps that meant getting parents together as a group, showing the tool, and being there to provide any extra information or questions they had about the tool. Accessibility varied greatly between the different groups. It was interesting to note that the French and Filipino community suggested small changes to the videos to increase credibility and understanding of the information, whereas for Indigenous and Somali healthcare providers and knowledge brokers, it was more about the barriers to accessing these tools. And one point that was very clear from the interviews with Indigenous and Somali healthcare providers was that relationship building was key and foundational to helping improve the accessibility and credibility of these resources. They said it would help inform the content and also improve the KT efforts that go out to the community. And that trust, I think this was mentioned in the previous presentation, trust and relationships needed to be built first before these tools would be considered useful. So I just really wanted to stress that someone often says, oh, you could just translate it into a different language. It'll be fine. It's quite easy. But we learned that so much time and care needs to be taken to ensure that all aspects of the tools are relevant to your stakeholder groups. It takes a lot of time and resources to translate these tools to other languages. And I think there could be more done in this space to examine how tools can be developed at the outset so that they resonate with multiple cultural groups. Unfortunately, to date, there's no model or best practices to achieve this. And we're hoping that through our work, we can start to put together some tangible recommendations and considerations on how to develop a tool from the outset that incorporates all these moving pieces to reach different audiences. Some of our key takeaways I wanted to highlight was that translations must go beyond the literal interpretation and include culturally relevant language and concepts. When choosing a format, you need to be aware of the accessibility present in the target community. Consider depictions of diverse living environments, resources, and relationships to increase relatability. And effective communication and collaboration stems from meaningful connections with each community. And I think that's a common theme we're going to be seeing today. And then the final thing is just that stakeholder engagement is at the heart of everything that we do, and it really is key to actually being successful in this space. So this kind of leads into Dr. Hartling and Julie's presentation next, but having a better understanding of the considerations needed to make our tools more accessible has really stemmed from this work. We've got expanded the settings for the tools, as Dr. Scott presented, like we've got different family dynamics happening in the tools, and a better understanding of the considerations to make the tools more accessible to different audiences. And one thing that's been developed fairly recently is our Pediatric consultancy network, and Dr. Hartling will talk more about this, but this really supports our focus on increasing diversity in these tools and getting feedback on the tools from a broader audience. And then the final thing we're working on is a systematic review just to understand what's been done in the space previously in terms of developing or adapting resources for different cultural groups, because in some other fields of work, so implementation science, cultural adaptation has been looked into, but in terms of knowledge translation strategies, we're still relatively new in this area to understanding how best to make that happen. So I think I've raced through that in the interest of time, but does anybody have any questions, I guess, Kelly, for Dr. Scott or myself?
Sure, that's wonderful. Thank you both for sharing your experiences as insights. And we did have one question in the chat. Erin asks, Dr. Scott and Sarah, did you include pediatric mental health concerns in your study, as this is an underserviced area?
Yeah, great question. We're constantly developing new tools, and our selection of topics for our tools is driven by the results from the needs assessment, so results from parents, as well as priority setting exercises. And yes, we are starting to develop tools in the mental health space. And Sarah, I don't know if you want to talk a little bit more about that.
Yeah, sure. So a priority setting study that our group was successful getting funding from WICRI for, I think, 2 years now. We surveyed Alberta parents and youth around what were some of their priority topics in child health, and unsurprisingly, mental health was a key topic. So we've currently just done an environmental scan to understand what resources are currently available to youth wanting to know more about the signs and symptoms of anxiety and depression. And that's some of the foundational work that could be used to develop a tool to support youth in finding resources for mental health. And interestingly as well, when we were talking to Somali knowledge brokers, they suggested that youth mental health was a priority area there as well. So that was a tool or an area of work that they would like to see more done in. So we're definitely aware that that's a priority area, and we are looking into it. Yeah.
That's great. Thank you very much. And that's a great lead up to our next presenters, who will be talking about working with a parent advisory group in knowledge translation. So as our presenters get their slides queued up, I'll say a few words about them. Dr. Lisa Hartling is a professor in the Department of Pediatrics at the University of Alberta, and she is a Canada Research Chair in Knowledge Synthesis and Translation, and a distinguished researcher with the Stollery Children's Hospital Foundation. Dr. Hartling holds several leadership positions, including Director of the Alberta Research Centre for Health Evidence and Co-Director of Cochrane Child Health, and as well has a role with the TREC organization, which is a national center for excellence for knowledge mobilization in pediatric emergency care. And our parent speaker, Julie Leung, has been with the Parent Advisory Group for a number of years. Pardon me. Excuse me. Julie's interest in research began as an undergraduate student in biology, but her interest intensified after her experience caring for 2 children with atopic conditions. Julie followed every suggestion from their doctor, but only was able to find solutions when she really dug into doing her own research into the conditions and finding solutions on her own. And it's an approach that she still wishes would be validated in a large scale scientific study. That research experience led her to begin pondering how medical research topics are chosen, how evidence is generated and put into mainstream use, and also seeking to understand how to become involved in informal research as a patient to provide feedback into the research process and the efficacy of treatments and areas of studies. So welcome to both of you, and I will turn the mic over to Dr. Hartling and Julie.
Okay, thanks very much, Kelly. Can you give me a thumbs up that you can hear me?
I can hear you and we can see your slides.
Okay, great, thanks. And can you see when I change my slide?
Yes, it all looks good.
Okay, thanks very much. So good morning, everyone. Julie and I are going to be talking specifically about the Parent Advisory Group. And as Shannon already introduced, the group is really at the center of the development of our KT tools and a critical factor in our research program. We have no conflicts of interest to declare. And again, as Shannon mentioned, we wanted to acknowledge our generous support through these organizations for our work. So our objectives of this presentation are to describe the development and evaluation of a parent advisory group to support our research program in knowledge translation, and also to provide reflections both from the perspectives of a researcher, myself, and a parent advisor. So we'll talk a bit about our accomplishments and challenges. We'll talk about some considerations we've had along the way regarding equity, diversity, and inclusion. And we'll also touch on what, I guess, our reflections around what we consider to be meaningful engagement. So just as some background, Shannon and I developed the Ppag, the Parent Advisory Group, in 2016, actually with support from Kelly. And we made it, or we intentionally created it as an advisory group. So they would advise us, provide advice, guidance, and knowledge from a parent perspective, and also partner with us in terms of co-developing content for our KT tools. And we built on the model and experience of a parent advisory group that had been developed through TREC to support TREC's activities. And Shannon has also already talked about what TREC is. Interestingly, that group is no longer functional. They parent group with TREC Central. But that's the model that we use to develop our own advisory group. Initially, we had funding. We had a small community engagement grant from Alberta Innovates Health Solutions at the time. And that really helped us set up the group and launch the group. And then Shannon and I were successful in getting long-term funding through the Stollery Science Lab. So that provides 5 years of funding and supports our stakeholder engagement coordinator who manages the group. So right from the outset, we also wanted to embed regular evaluations. And we did this so that we could understand parent expectations and motivations for being involved in the group. We wanted to offer an anonymous mechanism so that they could provide us feedback. And we also wanted to ensure that members felt meaningfully engaged. So at the outset, we did some careful planning, thought through our eligibility criteria, what the purpose of the group would be, and the role of parents and what our expectations would be of their involvement in the group. Initially, we recruited through 191 local and regional organizations throughout the province, and we looked across sectors. So we advertised through the health system, for example, as well as the school boards, and many other community groups. We also do regular recruitment. So each year, usually during the summer, we do a recruitment campaign just to replenish the group as people drop off of the group. And again, we're always looking to increase our diversity among the group. So we intended the group to be self-governed. We have a chair selected from among the parents, and we have a paid coordinator who supports the group. Currently, we have monthly meetings from September to May or June, depending on how much we have to speak to them about. And the compensation guidelines have really changed over time since we started this group. Currently, we offer our parents a gift card twice a year for compensation. So initially at the outset in 2016, we had 12 members. 8 were mothers, 3 fathers, and 1 grandfather. 4 of our members identified as immigrants to Canada, and they brought a real varied experience in terms of work experience across different sectors, including health system, business, education, media, government, and NGO. At the outset as well, we really spent some time to think about the principles and values of the Ppag. And I won't go through this in detail, but I just wanted to point out that inclusivity and diversity were really identified as core values that we wanted to adhere to as we worked with our Ppag. So like I said, we embedded regular evaluations. these are the results from our 1-year evaluation. So after the first year of operating the group, and these results have recently been published, and the citation to that publication is at the bottom of the slide. Again, I'm not going to go through each of these points in detail, but we did summarize what the parents felt to be good things about the group, and then what the parents thought the group could work on. And one of the good things they did identify with the group at the initial stages was the diversity. So they identified that it was a diverse group and that there was a range of opinions and points of view. Several things that they identified that we could work on was reinforcing that all opinions are valued, respected, and heard, and to ensure that everyone has the opportunity to express opinions. And I think that really resonates with that concept of engagement and really what is true, meaningful engagement. This is a summary of the researchers' experience, again, that we documented in our recent publication. So this was after the first year, about 16 months of running the group. So from the researchers' perspective, anyways, we really identified that the group is a dynamic entity, and there needs to be that iterative and ongoing feedback process between the researchers and group members. We also identified that there is a substantial investment in terms of time commitment to foster those relationships. And to do that, we also needed dedicated funding and resources. We needed funding and resources for the parents themselves to be able to participate, and for staffing to ensure that we could communicate and develop those relationships on an ongoing basis. Communications obviously were a key item. And we also heard from the group that they wanted follow-up regarding the outcomes from each project and activity. So it wasn't necessarily enough just to get their feedback on different initiatives. They also wanted that feedback loop. Okay, how did you use that feedback? Also, how does it fit into the bigger picture? And not just the bigger picture of our research program, but they also wanted to know, how does this fit into the bigger picture of the health system? Two things that came up that we didn't anticipate, or that we, I guess, navigated along the way, was ethics approval. And so in order to do these evaluations and to be able to share our results with the community, the scientific community, we had to get ethics approval to do the evaluations. And this creates a bit of a difference in terms of that relationship with the parents. Suddenly they become participants, research participants, and are having to read and sign consent forms. And it kind of changes the nature of that relationship, and yet we thought it was a critical component in order to be able to just rigorously assess how we were doing. Also, training came up. We asked our parents initially if they wanted training around research methods, how research is done. And resoundingly, the feedback we got from our parents was that they didn't want the training because they felt that would also change the nature of the interaction. So they wouldn't still be that typical parent anymore. So we've carried on our annual evaluations, and these are some points from our most recent evaluation. So this is 5 years later. We have a group of 24 members now, and we've really increased our membership because what we found was that only about maybe 10 people attend any given monthly meeting. And so we wanted to increase that pool so that we would have a good attendance to have fulsome discussions at our meetings. I just wanted to point out among these points is that under what could be improved, our parents have flagged that more diversity among the members would be something to aim for. So in an effort to try and increase diversity, we've tried along the way, we've really tried to recruit with that in mind. But this year we also launched what we call the Pediatric Parents Consultation Network in an effort to increase diversity and diverse feedback and opinions on our activities. So you'll see one of the key letters in this acronym that's different from Ppag is the C. So this is meant as a consultation group as opposed to an advisory group. And this is a national network. So we have gone across the country to recruit members, and we intend to involve them on an ad hoc basis to give input onto our knowledge tools and some of our other research activities. This is what our consultation network looks like currently. We have 36 members from 8 provinces, and we have collected in an anonymous way demographics about them. And I won't go through this detail now, but again, that's our intent, is to seek that diversity in terms of all of these different features: race, ethnicity, education, marital status or family composition, household income, and geographic area. So just a few thoughts from my perspectives to sum up. I feel like we have achieved a model whereby we can co-develop in true partnership with our parents' knowledge translation resources. But what we've found along the way is that this involves a tremendous amount of time, resources, specific skill sets, a lot of careful planning, and that ongoing evaluation to ensure that we're achieving our goals. I think our outputs have changed tremendously. Our parents give us a lot of really good feedback and are really open about the feedback. In terms of the impacts in terms of health outcomes, we don't regularly measure that. And I think that is a weakness right now in the KT space. What does meaningful engagement look like? That's a question that has come up in our discussions over the past 5 years. And the other thing is, does it mean the same thing for research as it does for patient partners? And I think that's why the evaluations are so important, so that we can gauge that. The other question that's come up is, what does true diversity look like and how do we achieve it? So we really have made that a focus. Like I showed in our original values, inclusion and diversity were key values, core values at the outset. We try to recruit and we've extended and developed the consultation network with diversity in mind. Have we achieved true diversity? I don't know. But I'll leave it there. So I'll stop sharing my slides and pass it over to Julie.
Thanks, Lisa. I'm just going to share my slides now. Okay, can I just get a thumbs up that you can see the big screen and changes when I change? Awesome. So, hi everyone, I'm Julie Leung, and I am a member of the Parent Advisory Group. I've been a member since fall 2016, so nearly since inception, because I think there was one meeting in the spring just before I joined. And as you've just heard from Lisa, there's been constant evolution. There's been lots of evaluation and feedback cycles, and I've observed the evolution of this group throughout that 5-6 years. I'm going to be presenting a little bit about my reflections on this group and membership in this group from other vantage points. So interestingly, my involvement in the Ppag is a springboard. It turned out to be a springboard for lots of other, I guess, engagement on small and sort of big levels with members of the community that these researchers are a part of. And then sort of those people sometimes had springboards to some other studies and other researchers in child health. So I've been able to reflect on what this group looks like and how it's unique and different than some of the other groups and what they're trying to get going for patient advisory. And then I'm just going to leave us with some three ongoing considerations and questions to ponder in regards to involving stakeholders and trying to get diversity in those stakeholders. So as I mentioned, the connections with other groups that I've had has enabled me to sort of see the ECHO and ARCH Ppag from a different vantage point, and to compare and contrast, and to see that there are some really unique things. So I had forgotten I'd used this term bleeding edge, but I guess I said that to Lisa and or Shannon. My view is that there are some bleeding edge things about this Ppag. So first of all, there's an established framework of regular meetings. So we used to meet every 2 months. And then the feedback actually given from the parents was that we actually would like to meet more often if you would like to meet with us more often. And there is that ongoing framework of regular meetings. We know when they're coming, they're all planned in advance. There's a pipeline of tools and initiatives that are being evaluated. So every time we come to a meeting, we see that there's just a multitude of things that are happening and tools that are sort of on the horizon, and they kind of shuffle in, we give feedback, they shuffle out, and there's more coming. Early on, there was a desire for this group to ultimately become a bit of a specialist group that other researchers could come and access. And I've seen that happening over the years, where there are researchers that are kind of affiliated with the Echo Arch team, and sometimes they'll come and pick our brains as well. We meet on parent schedules, so all the meetings are at night. And you wouldn't think that that would be significant, but there are groups that I have interacted with where they're really interested in doing POR and involving patients or parents, but then they schedule meetings in the middle of the day when they're working. And we are often working as well. So, you know, it's really difficult to balance that when we have careers of our own and we're trying to volunteer as well. Respect and having an equal voice is really kind of unique in this group. I think there's a real commitment to trying to view us as an equal partner. And you've heard Shannon kind of mention that, and Lisa mentioned that as well, that it's a co-development with the parents. Then the dedicated coordinator to engage with parent members, I think, is really important because there's just so much effort and work to booking the meetings, setting the agendas, and it turns out actually engaging with us when we have concerns or however that might look. And I think that when you're a researcher and you have a research focus, sometimes you don't have the time to dedicate to engaging with parent members. So having a dedicated coordinator, which this group does, is really important. There's been, as you see, a demonstrated commitment to the evolution and continuous improvement of the group. And in my view, there's a continuous forward momentum. So, I mean, the launch of the PPCN this year, there were meetings where we talked about what are your thoughts on, you know, how we do social media strategy, how we engage social media, what's appropriate. There's an app in development. There's things that are changing, and this forward momentum that is a little bit different than just looking at KT tools. And as alluded to before, there has been a feedback loop for the parents that has been implemented with this group. So it turns out that, like everybody else, parents and volunteers want to know, what is the outcome of what we spend our time doing? How does our input shape the knowledge synthesis products? So the priority setting kind of exercises. How does what we say improve the KT product? So having opportunities to see the tool that we commented on kind of come back and, you know, seeing the differences and getting a report on you know, what we said, and then how that shaped or changed what they took away and then kind of implemented. And of course, seeing the context of our work within the larger machine, both in the Ppag, that clock that Shannon talked about, as well as the larger health research machine. And what I've noticed is in other research groups, despite an awareness of the value of patient-oriented research and a real desire to start some sort of advisory group, those research groups seem to struggle to know where to start with setting up patient advisory. They struggle to dedicate the time, effort, and the funding that's required to get something like this going and continuing, and to appreciate the parental need for feedback when we volunteer time, you know, that it doesn't just disappear into a black hole, that we get some sort of feedback. Thank you for that. And this was how it was useful. So I think the findings of, you know, and the evolution of this Ppag group inside Echo and Arch have uncovered not obvious concepts. Like, you'd think they are obvious, but then they're not, to facilitate advisory and POR. And because of that, has demonstrated a bar setting level of maturity and evolution. So what do parents get out of our involvement? And I can only really speak for myself. So I've had lots of opportunities in my involvement with the Ppag, and then sort of some of the things outside the Ppag and things that I do kind of with this team that aren't specifically in the Ppag group. So I've been able to see lots of facets inside research, like what it looks to, you know, be involved in grant writing, ethics review, manuscript drafting, seeing peer review feedback and giving the responses to that feedback, and publication. I've gotten a chance through PERC to see a little bit about clinical trials, and to learn that knowledge synthesis and knowledge translation are concepts and how they differ from each other. That has been kind of unique for me. I love having opportunities to meet and get to know people in the child health research network in Canada, and to interact with and access leaders in child health research. Shannon and Lisa are Canada research chairs, and I consider myself privileged to be able to interact with them and to have a relationship as well with Sarah. I enjoy having an opportunity to improve child health outcomes. And finally, this last bullet, the access to the lock tower. And what I mean by that is, Kelly gave a little bit of a background of why I got involved in volunteering in health research. And it really is this concept of wanting to have some sort of input, but really realizing that that's the world of research is like a little tower that somebody like me, even though I am science oriented, I've got a science background, really cannot access because I don't have credentials and I don't work in academia. So my involvement here has really given me an opportunity to see a little bit inside this world, have relationships inside this world, see what happens and have some input into it, which is really valuable for me. So I'm just going to leave with 3 last ongoing considerations around involving stakeholders and diversity of stakeholders. So I think one of the things I've seen in the last couple of years is that there is a difference between parents or stakeholders with general knowledge about the things that you're developing. So for instance, me giving input on a tool about bronchiolitis versus someone with a lived experience. So an example, me giving input about anaphylaxis because my children suffer from food allergy and realizing that both are valuable. But the consideration there is, when is that lived experience parents' feedback not helpful because it's too specific, and when is it actually required? And really it is understanding what is the audience that you're trying to engage, obviously. The second consideration, which we've talked about a lot, is this ongoing need to recruit for diversity needs to be front of mind, and it is for these researchers. And the challenge here is because many Ppag members are just by nature going to be more like the researchers than the typical parent. Ongoing and long-term engagement in work like this is driven by some sort of meta interest, which really mimics the profile of a researcher or a healthcare professional. So the interesting point here, I think, is that, I might be similar in lots of ways. And in fact, I was sitting in a PERC meeting last year, and one of the doctors said, "You're more like a researcher than a parent," because I'd said, I value this because then my kids more or less get to be a data point in research. But what's interesting about that is, even though I might be similar, I am still the other, because there is this concept of, experience and lived experience. And the fact that I have not grown up in academia, I don't work in those fields, I don't have that experience, and I don't have those viewpoints, I guess, still makes me the other. And I think that's kind of a unique thing to recognize. But the consideration then is making that balance between, when you recruit and you kind of end up having people that are long-term engaged because they're really interested in what you do, because they're kind of more like you, balancing kind of wanting to have that long-term engagement, but then you run the risk of having sort of an echo chamber in your advisory. The final consideration is this sort of, I guess it's emerging. I've heard kind of emerging thoughts about having, taking SPORE to the point where you have patient partners basically as equal research members, to the point where some of them might actually be leading studies and they're patient partners. And the real question is that really possible? Because obviously there's a training differential. How does a person who doesn't work in academia, doesn't have the credentials, how do they lead a research study and know how to do that? But that is also fundamentally part of the value of being the other, getting to that point where that other can take on that type of role or leadership in a research study is kind of interesting. And finally, that really having true respect and equal voice, being treated as equal partners at the table, de-risks tokenism. So there is kind of a sense sometimes that PORE is this emerging great thing. And so sometimes researchers, I think some of us as parents get the sense that sometimes researchers want to check that box and say, I've done PORE, it's great. Look, I had an input from a parent or a patient or however that looks. And so if there is that true respect and that treatment as part of the research team or an extension of the research team, that will de-risk that feeling of tokenism and then the risk of disengagement. That's all I had. And I just wanted to kind of thank you on behalf of Lisa as well for listening and open the floor to questions.
Thank you so much, Dr. Hartling and Julie. And Julie, it was so amazing hearing your perspective, and I really am appreciative of the key takeaways from your presentation and how they relate to patient-oriented research. So in the interest of time, I'm going to hold the questions until the end if we have time. I'd like to move on to our next presenters. And I'll, just as you queue up your slides, I'll give an introduction. Catherine Turner is a Métis woman whose family originates from the historic Red River settlement in Manitoba. She is the Indigenous Liaison Manager for the Council CKD Network and also holds the position of Senior Research Coordinator with the First Nations Health Authority for the BC Kidney Check Project. Catherine has developed and managed Indigenous primary prevention health programs for the past 2 decades. She is a member of the Indigenous Peoples Engagement and Research Council, IPERC, and Wabishki Bishigu Skanj Learning Pathway Working Group. Catherine is a recent graduate of the UBC Indigenous Public Health Graduate Certificate Program. And presenting with Catherine today is her colleague Simone Du, who is a second-year graduate student at the School of Population and Public Health at UBC, finishing her master's degree, where her research focuses on evaluation of the kidney check, screen, triage, and treat program, running in 16 First Nations in BC, and uses an applied 2-eyed seeing approach. And Simone also works at the Council CKD Network partnership and training portfolio. So thank you and welcome both of you. And I will turn the mic.
Hello, can you hear me?
We can hear you. And
okay, great.
Your slide. Perfect.
Okay, thank you. Thank you. Welcome. Today we are presenting on a 2-eyed seeing approach to integrated knowledge translation in Indigenous community research. Ppag is a guiding principle developed by Mi'kmaq elder, knowledge keeper Albert Marshall, that recognizes that better outcomes are more likely if we bring 2 or more perspectives into collaboration. It can also be understood as a gift of multiple perspectives. I want to acknowledge that I am a visitor on the ancestral unceded traditional territory of the Omox First Nation in the beautiful Comox Valley on Vancouver Island.
And my name is Simone. I'll be co-presenting with Catherine, and I am very grateful to be joining today from the Coast Salish territory, which is the ancestral, unceded, and occupied territory of the Musqueam, Tsleil-Waututh, and Squamish First Nations. And I'm very grateful to be a guest on this land today.
In our presentation, we will cover what the Council CKD Network is, equity, diversity, and inclusion in action using the BC Kidney Check Project as a model, the Kidney Check Project focus, what inclusive community engagement can and does look like. We will share testimonials from project participants. We will share personal experiences of diversity in a research team. And in closing, we will summarize our presentation. The Canadian Seeking Solutions and Innovations to Overcome Chronic Kidney Disease, CanSolve CKD Network, is one of 5 networks established through the National Strategy for Patient-Oriented Research to focus on chronic kidney disease. We have 18 research projects across Canada. 3 of those are specific to Indigenous populations. Our vision is that every Canadian with or at high risk for chronic kidney disease will receive the best recommended care, experience optimal outcomes, and will have the opportunity to participate in studies with novel therapies, regardless of age, sex, gender, location, or ethnicity. Having 2 patient-led councils at the center of our governance structure is what makes us a truly patient-centered network. These councils, the Patient Governance Circle and the Indigenous Peoples Engagement and Research Council, IPERC, are true decision-making teams that guide and advise the whole network. We are a national network that brings together kidney patients, researchers, healthcare providers, policymakers, and caregivers. We are a group of over 150 people from across Canada. The network's strength lies in diverse perspectives. Patients are working alongside researchers, healthcare providers, and policymakers.
So integrated knowledge translation is really at the core of how we do research at CanSolve. And it began with building relationships with patient partners and working from the inception to embody this core value of nothing for them without them. So through that relationship building, we were able to use this collaborative model of doing research, IKT, where researchers work with stakeholders and knowledge users, our patient partners, to identify relevant problems and have the authority to shape and implement research recommendations. And that represents the I, the integrated in IKT. And then through our work at the network, we honor and integrate and incorporate multiple sources of knowledge. And our goal is to ensure the timely translation of this evidence that we have collected into practice so that it can actually improve the lives of the people living with kidney disease, of our patient partners, to really close that circle.
Equity, diversity, and inclusion in action. The BC Kidney Check project model, identifying kidney disease and diabetes in BC First Nations communities. Our project focuses on implementing a better way of identifying and treating kidney disease and diabetes in Indigenous communities. Indigenous patients are our partners in designing, executing, interpreting, and communicating this project. Authentic relationship building is instrumental to our approach in this project. We invite instead of impose participation. We honor the self-determination of individuals and community. We take time to spend with people, thereby cultivating trust.
It's really important to note that embodying the approach that Catherine just outlined on the slide previous was really an active process for many Kidney Check team members, specifically non-Indigenous Kidney Check team members. Because this approach is really rooted in Indigenous ways of doing, it required team members to go through the active process of unlearning their typical approach to a research project, which meant embracing discomfort and recognizing and challenging biases, both conscious and unconscious. And it really represented a paradigm shift for many team members, and one that required really active engagement and constant reflection throughout.
The process. An expression of interest letter was created to initiate the process for the First Nations health directors and community leaders to sign up for the Kidney Check project. A Kidney Check information table was hosted at various Indigenous events. We received 28 expression of interest applications. The 28 applicants were contacted by telephone to assess each community's readiness to participate in the project. From this process, 10 communities were selected to participate in the Kidney Check project. With the realization that the 10 participating communities were very diverse in size, customs, and resources, we designed a menu of services to assist communities in selecting what model would best suit their community. Telephone contact was made with the community contacts to identify the best model for the BC Kidney Check in their community. I think it is critical to have Indigenous team members when working in Indigenous communities, to have them as patient partners, as partners in the work, as staff members, as Indigenous representatives, and knowledge keepers, for example. Take the time to immerse yourself in Indigenous culture. to learn about Indigenous ways of doing that will foster greater understanding. We are committed to reconciliation with Indigenous peoples, and so our project activities, marketing strategies, inclusive of all the work that we do, is guided by a truth-telling approach. In this photo is an Indigenous patient partner, Elisa Asu. She is a valued member of our team. She attends, when possible, kidney check events to share her lived experience with chronic kidney disease. Following one of our community engagement sessions, we carried out an evaluation. And here are some of the comments. We asked the question, what is one thing you learned at this event? And these are all Indigenous participants. Kidney screening isn't as scary as we thought, that there is hope for people. I learned what causes kidney problems and what keeps us safe from kidney disease. We asked, are you planning on attending to get your kidneys screened? 36 of the 38 respondents said yes. The 2 who said no were visitors to the community and were unable to attend on the screening date. We asked, is there anything else to share? Please keep coming back. Everything was done very well.
So like I previously mentioned, my thesis research was an evaluation of the kidney check project that Catherine has just outlined, really using a qualitative approach that was framed in narrative, so storytelling, and guided by the core values of Indigenous evaluation. So I interviewed a number of screening team members, so members of the kidney check team, who were responsible for organizing and implementing the project in communities. And I was looking to collect information on the value of the project and on its sustainability moving forward. And like Catherine may have alluded to, a central tenet of this research is that it proceeded using a two-eyed seeing approach, or a Ataptamunk. So using the strengths of both Western and Indigenous ways of doing together. And what allowed me to foster a genuine two-eyed seeing approach was the relationship that I had and have with Catherine and her guidance and mentorship throughout the process. And I'll come back to that in just a second. But first, I wanted to share some of the quotes from the results of my evaluation that really echo and demonstrate what Catherine has explained in the words of kidney check team members themselves. So on the topic of diversity in teams and Indigenous representation, I heard consistently from participants, both Indigenous and non-Indigenous, that having Indigenous team members was essential to the project, not just at the individual level, but also in terms of like governing bodies and group stakeholders. So this one participant explains, I think the partnership with the FNHA kind of allows that. Communities to know it's endorsed or supported and partnered with the FNHA. So it's a little bit of reassurance to community. Another piece that Catherine mentioned was how the project proceeded in a way that honored self-determination both at the individual and community level. And a quote from an Indigenous participant here embodies that, saying, the whole approach I've taken with this project has been not me imposing what I feel the community needs or what the community wants or how I feel this would work best for them. So from the beginning, the approach that I have taken has been honoring the self-determination of communities. And lastly, like I mentioned, the whole paradigm shift and this new approach was an active process for a lot of team members and required them to walk this learning journey. And I heard that echoed in the interviews as well. And I'll just share this quote from non-Indigenous participant who says, I think I've had to let go of all of my former research ideas. In the beginning of this project, I had Gantt charts, I had it all laid out when we were going to do the screenings in which communities, and now I've had to let that all go. And lastly, what I think is really important to touch on because it resonated so deeply throughout the interviews with the screening team members is this relationship between the capacity building, community driven approach that Catherine described and how that relates to sustainability. And this is a quote from an Indigenous participant who says, "I think there's a real opportunity for sustainability where the staff from the project are working with community to increase their capacity, their knowledge, and their ability to take this program and deliver it within the community. So I really appreciate the idea, the concept of ways to support and increase the capacity from within the community. And I think that's what this has done." So really just sharing some words from other Kidney Check team members that help kind of hit home some of the concepts that Catherine has shared. And then looking specifically at kind of my own research experience and my own process of doing this evaluation. Like I mentioned previously, Catherine's guidance was really absolutely essential to my thesis research journey. And Catherine actually sat on my committee as an Indigenous knowledge holder, and she was involved at every step of my research from the methodology that I used all the way to analyzing transcripts, and her feedback and her suggestions were always honored and implemented. And it was that allowed us to work together to embody a genuine two-eyed seeing approach. And Catherine also patiently guided me through concerns about cultural protocols, for example, how to offer tobacco and how to do that virtually over Zoom. And of course, maintaining the cultural safety throughout the evaluation. And it really was the conversations and the mentorship that I received from Catherine that opened me up to a new way of knowing and doing that was essential in doing this evaluation in a good way, and in a way that was respectful to the community members and would provide results that were relevant to them as well. And being a settler myself, it was hugely important to be mindful of my own positionality and the biases that I carry, and the potential that there was to do harm, as other non-Indigenous external evaluators have done in the past. So building this relationship with Catherine and having her guidance was so central to keeping cultural safety and humility in the forefront. And I think we've heard this kind of echoed in some of the other presentations today, but relationship building was maybe the most foundational piece of my thesis research in terms of the relationship that Catherine and I built. And it took time to build an authentic relationship that had trust and openness, but that was so essential to our working relationship and our collaboration through the research process. And really the reciprocity that was in the forefront of our relationship as well. Obviously, I learned a tremendous amount from Catherine, and I'm very grateful for that. So doing this evaluation work as a team, as a non-Indigenous student and an Indigenous mentor, is what allowed the evaluation to really have the impact and outputs that were important, and that it did. And I'll pass it off to Catherine now to share some of her experience.
Further on reciprocity, principles that we include in the Kidney Check project are fostering a give and take, relationality, community capacity building, increasing health knowledge, other considerations, asking ourselves, are the Indigenous individuals, the community, and the nation benefiting from the work, the research, the project that we're doing in their community? We are constantly looking for ways to support local Indigenous economic development. For example, hiring an Indigenous caterer for meals when we gather. Is there a local artist who is interested in designing a logo for your marketing materials? Is the health of the community members going to improve because of the project? Some of my thoughts on the relevance to this project. Is the project a priority for the community at this time? Rather than leading with an idea or a project, it is best to be invited by Indigenous groups to do research they have identified as a priority, thereby respecting self-determination in research. Next slide. In summary, the BC Kidney Check project is guided by a two-eyed seeing approach. We embed Indigenous ways of knowing, doing, and being in community-based research. We embrace being comfortable in discomfort. For example, as a non-Indigenous researcher, it's okay to sit within a quiet space, within an Indigenous environment. You don't need to fill in that space with your words. Be present. Value people in their diversity. We all bring unique gifts to the table. Provide opportunity, but don't impose. This is true equity. Take the time to understand the community needs, and this will have a real impact.
And looking again, just coming full circle to that integrated knowledge translation piece, there's such strength in building research from the ground up with all stakeholders and investing in authentic relationships at every level of the research team and of the research work. But it's very important through all of that to stay flexible and to prepare for changes in plans, but that all ultimately contribute to the betterment of the work. And with that, I will say thank you so much for your attention. And I guess we'll welcome any questions. Catherine, anything else?
Not at this time. Thank you.
Thank you so much, Catherine and Simone. That was just wonderful. And in particular, thank you so much for highlighting relationships and telling us more about reciprocity and the role of that in the two-eyed seeing approach. Yeah, I'd like to invite some questions. And I guess to kick things off, I'll start with this question. What would be, for a researcher who is starting an initiative with an Indigenous community partner, what would be some of your top advice for initiating a relationship and getting started?
So from my perspective, and as we have mentioned throughout our presentation, relationship building and trust building is critical to moving forward with work in Indigenous communities and with Indigenous people. It does require patience, being present. There is a plethora of Indigenous resources that can be accessed to learn more about Indigenous peoples in your area and the people that you plan on working with. I would suggest attending cultural events and ceremonies, if possible, to the best of your capabilities. Simone?
I think I would echo everything Catherine said, and from a settler perspective, really working to let go of your own preconceived notions of what the experience will look like or what it should look like or what you want it to look like. There's a lot of Western ways of doing in research that do not fit with Indigenous ways of doing in research. And so being able to recognize that, embrace the discomfort of using a new approach to a research project, but really letting go of ego, for lack of a better term, through that process. Yeah.
Excellent. Thank you very much. Another question, a question about how COVID may have impacted your project. And I recall during the presentation, Simone, you specifically talked about virtual gifting of tobacco. Tell me more about how COVID impacted the project.
I think there's two levels of impact here. There's the impact to the overall kidney check project, which Catherine can speak to, and then of course the impact to this evaluation work. And I initially, when I came onto this team, we thought that the evaluation work would look like going into community and doing sharing circles with community members who were screened. And obviously in March of 2020, it became super apparent that that wasn't going to happen, that transitioning to a virtual environment was going to be necessary. But in the Indigenous health field, and especially as a settler, you know, that in-person relationship building, that face-to-face communication, that authenticity, that trust building, it's really challenging to do over Zoom and email. And so it did require some flexibility and some additional effort. And you know, like, for example, offering tobacco through a computer screen and then laying the tobacco down yourself later, or mailing it to the participants, was something that I had to navigate. But I mean, I'm grateful for the use of Zoom and for the use of online platforms, but I will say I don't think anything can really replace that face-to-face communication. And I'm hopeful to recoup that lost time at some point in the post-COVID future. And I'll pass it to Catherine, I think, to speak to more of the Kidney Check project in general.
Thank you. So on March 13th, the project, that was 2020, the project nurse and I returned from a community engagement session in the interior region. Our plans were to begin screening in 3 First Nations the following week. We were notified of COVID and suddenly everything stopped. We certainly had not anticipated that the effect this was going to have on our work and the extended time frame that COVID was going to have on our work. So in the months that followed, we maintained contact with and relationship building with the communities who are participating. And from that, we developed a strategy to continue with screening if and when communities had been fully vaccinated and were ready to embark on screening activities again. So the BC Kidney Check team created a virtual training session, which took place over 2 days. The project nurse, the project manager, patient partners, an FNHA physician, and myself presented on the project. And so training took place, point of care screening, led by the project nurse, Beth Nielsen. And we have since hosted 2 virtual training sessions. One took place in March of this year. And the community who participated in that training followed up with screening in community and screened 27 individuals in their community. We recently hosted another virtual training event for 2 communities, and screening activities are going to commence in September and October.
Fantastic. That's great. Thank you so much for that response. So we are at the end of our session time for today, and I apologize for not getting to all the questions in the chat, which you had some great questions. But I will wrap it up and say my sincere thanks to all of our speakers today. It was just so great to hear about your experiences and your insights, and we all walk away with this with much value to inform our work as we move forward. So thank you, and thank you to all of the attendees who came and participated